think we can you see the IVUS image? Okay, so basically what we see here, this is in the RCA. As you saw, there was a diffuse disease. There are 3 points by angio. There are more significant stenosis. We could not advance the IVUS catheter for the very distal lesion, just because of the calcification and the severity of stenosis. So what you're going to see here, it's IVUS run starting from proximal to that very distal lesion. And I'm just going to show some steady images here. So this is the distal reference, about 2.5 to 2.7. We had 3 spots that we saw the most significant lesion, 3 different spots. Here's the area 1.54, where you see a very fatty tissue, maybe more fibrotic at this spot here, with a 77% plaque burden. Here's another spot we can see the calcification, maybe more than 100 degrees of calcium here, from 4 to 9. Also a very small area by IVUS. Advancing more proximally, another spot, 2.41, more than 70% damage stenosis. And here, that's in the mid portion, just between 2 small acute marginals. We thought this could be a good landing zone. This is a proximal reference considering only the lumen about 3 millimeter diameter. The vessel is larger, but maybe this kind of severe diffuse lesion, we might want to consider a proximal distal reference, the lumen, not the vessel. And also, we saw mild to moderate proximal lesion in the RCA, which we saw a plaque burden about 66%, a vessel around 4 millimeter square, 4 millimeter diameter, but a area here about 4.51 millimeter square. So if you want to use some of the previous IVUS criteria, we would feel very comfortable to not touch this lesion with this kind of area we have here.
Okay. So based on these IVUS results, we decided to okay. We decided to pre-dilate the distal lesion. It's a very tight lesion, so we did the pre-dilatation of it.
I'm sorry. To show you the IVUS run, it's for better understanding and for better comprehension. If you have the run of the IVUS, it would be better.
Okay. Okay.
And the question is, based on the IVUS, how long of a stent you need to use, because it's very hard to get the impression just for the still pictures.
Sure.
Yeah, but we can show the run. So if you can have the IVUS here.
Use an IVUS.
Yeah, it was difficult. It was difficult to give the length.
Potentially looks like lesions.
Mostra na tela.
We end up stenting far more than we would. My philosophy in these is, and that's when we come to FFR, why not use, I think we should be using FFR in this vessel. Treat the tightest lesion and then decide on the rest using FFR, and that's what I generally do when treating diffuse disease. Relying on IVUSs makes us overstent a vessel with multiple stents rather than stent the target lesion itself. And
so you would use just FFR first, or you would use...
No, if the lesion in the proximal mid-segment was clearly high-grade 90%, which needed treatment, but after that I would actually run an FFR throughout the vessel, knowing which lesion to leave and which lesion to treat. And that's a pull-back FFR perhaps would be the best tool for this LAD.
Yeah, okay, that's run, give us some impression. George, would you use FFR, IVUS, none of the above?
I think it's very useful to see the entire IVUS run. I agree with that, so you understand how much you can cover or not cover by the stent. I think an FFR might be more advantageous to overall assess the situation in that vessel.
Yeah, I mean, we actually find the formulation, it's not only us, I think S.J. Park does a lot and others publish that the conversion criteria is not 4.0 to 0.8, it's more close to the 0.3, and in small vessels it's even less than that. It is really hard to do just based on IVUS, but I think IVUS, if you use the right criteria, you may be able to determine also some physiologic assessment, even though it's just an anatomic view.
So, Majoni?
Oi. Okay. Have you seen the IVUS run? Okay, we have done the following. We have pre-dilated these lesions with a 2.0 balloon, and we implanted ion stents. Ion is a new stent from Boston Scientific. The alloy is platinum chromo. It's a good visibility, as you know. The drug is paclitaxel, and the paclitaxel in diabetic population showed favorable results, as showed in the trial comparing with Zeiss, the Spirit trials. So we decided to use this new stent from Boston Scientific. So we implanted a 2.5 stent, 28 of length in the distal part of the artery, according to the IVO results. We implanted another stent performing a small overlap between the stents, as you can see in the screen. So we decide to cover until the mid portion of the right, that I will show the proximal part. There is no important lesion to be treated. So we did the implantation. And we perform also a post-dilatation with a 2.5? Trio non-compliant balloon in distal parts of the artery. And with the same non-compliant balloon with a higher pressure, we performed also a post-dilatation in the mid portion of the right. This is the final result of our stents in the right. This is the final angel. And we also have the IVOS result. Would you like to see the IVOS result now? The final IVOS of the right? Yeah, it's a full metal jacket. A reconstruction of the right. Rebuilding.
With this design are really nicely preserved. I mean, when you look at the angio post all the stenting, you don't lose a lot of branches there. It seems that most of them are there.
So can we see the IVOS run instead of just the pictures?
Yes. Yes. Dr. Ricardo is going to show now the IVOS.
We can give you the run, and then we can give some specific spots. So this is very distal. It's not a very big vessel. That's about 2.5. We were able to go up to the distal reference. So we started in the very distal portion of the stent. So basically what we see here, considered to be a good expansion of the stent, considering the vessel size. And then we can give you some numbers at the end. As you said, it's a full metal jacket. And there are some spots we can see the calcification, the calcium behind the struts, and sometimes it distorts a little bit the stent and impacts a little bit the area. But overall, we consider to be a good expansion after the non-compliant balloon, which was up to 16 atmospheres. So here we're probably in the transition between the two distal stents. So just saw the overlapping area. And here's some of the calcification part, but overall appears to be a adequate expansion. The landing is, we're going to see the landing zone proximally or a more calcified portion. The treatment here is very, very careful to implant the stent at the low pressure and then post-dilate with the high pressure, just to not cause any dissection proximally. Here we see a more of calcified part. Vessel gets larger here. We have a better expansion as well. That's a branch coming at 1. And we should be approaching to the proximal.
I think the question, maybe I'll ask Adriana.
End of the stent.
Spot stenting versus full metal jacket. Where do you decide to go for full metal jacket or spot stenting? Because there was a chance to do here spot stenting, even if the other lesions were significant.
I think that was a good approach. I like it. I think we have to cover most of the lesion. So I think we have a good result.
So you would go for full metal jacket, right?
Full metal
How
jacket.
about Arimandiu?
Well, with the FFR in the lab, I think the spot stent will be nice.
Yeah, if my partner Gas Pichard would be here, he would scream that he wants to see spot stenting. But often what happens when you do the spot stenting, you still have the gaps of some disease, and that disease looks even worse. So I don't know. You know, at the end, you add all those stents. So what I'd like to, if you make a decision to go with full metal jacket, you should use the longest stent that you have, and maybe you can end with 2 stents. So I think that the ion comes also on 38 millimeter, and you could have done probably with less stents, but I'm not sure if it's available.
I was just going to say that.
Waxman, sorry for interrupting you. We have 5 minutes left.
Okay.
So we have to go to the LAD to finish this case. Okay?
Perfect.
Okay, go ahead, please.
Go ahead. So we have also performed a pre-dilatation of the LAD with the balloon catheter, and also did the IVUS, a pre-dilatation of the LAD, as you can see now. This is the result after pre-dilatation of the LAD. Would you like to see the IVUS of the LAD? In the meantime, I can continue with my work, okay?
Yes.
Okay.
And while you're working, we are just discussing here, Mangione. So are you going to implant again an IO stent?
Yes, I'm going to implant again an IO stent. This is in distal part of the artery, and a 2.5 for 32. It's an IO stent also. There is an ongoing trial in India with this stent in the diabetic population, comparing this stent with the Zinc Prime.
Okay.
In diffusely diseased vessels, we've often found that while we use IVUS and FFR,
you may be too distal, by the way.
IVUS biases us towards a full metal jacket quite often in diffusely diseased vessels,
He'll have to add another stent.
while FFR helps us